Hi, I'm Tamara Kwarteng. I'm the chair of the board of the Multicultural Center for Women's Health. We are a community-based, not-for-profit organization based in Melbourne, led by and for women from migrant and refugee backgrounds. We exist to empower migrant women in Australia with information to promote health and well-being. I am a migrant woman. I was born and raised in Ghana and have been in Australia for 32 years. The picture you can see behind me is of a market scene in Accra, the capital of Ghana, where I grew up. But it actually could be a market in any town or village in the country. It talks to me because it shows a typical scene of a place where women are prominent. The marketplace, particularly markets that sell foodstuffs, clothes, are places where women are prominent in Ghana. They are not the only places where women are prominent. Women do have prominent roles in other parts of the community, of the society. But this marketplace really evokes one place where women's prominence and importance is abundantly clear. Hence, it's one of my favorites in the house. I do have a room of my own in our house, which is my study, but I've actually escaped from that for today because it is such a mess, and I'm sitting now on the sofa in our living room, which is actually the most comfortable seat in the house. So it is a sort of a room of my own. Because the only other resident of the house is my husband, and he spends a lot of his time in his study. So I do have this room, a living room, to myself a lot of the time, and sitting on a comfortable couch with my favorite picture behind me. My involvement with MCWH is in a voluntary capacity. My main gig, the gig that pays the bills, is as a consultant in international health. This means that I work in developing country settings, primarily in planning and or evaluating international health programs, usually programs that have been funded by the Australian government. So the COVID-19 crisis has put a stop to all travel and therefore work for me outside of Australia. So you can say that I have been grounded. I worked for about 30 years in developing country settings in the HIV prevention, care and support sector. I cannot help but notice that the issues that influence and continue to influence risk and vulnerability to HIV infection, such as gender, class, poverty, ethnicity, are the same issues that we are seeing influence the COVID-19 crisis. In other words, the pandemic is shining a spotlight on the fault lines of our society as the HIV epidemic did some 30, 40 years ago. In other words, we have been here before. What did we learn from dealing with the HIV epidemic that we can bring to working on the COVID-19 crisis? We learned from the HIV response that the most effective responses are those that involve affected communities from the beginning in the planning of the response, in deciding what to do and how to do it, and in fact, supporting the communities to lead the response. In drawing further analogies between the HIV epidemic and the COVID-19 crisis, it has been said that the HIV epidemic posed a triple jeopardy for women, in that women were at risk of infection themselves. If they were infected, they risk passing the infection on to the child, unborn child, during pregnancy or through childbirth or through breastfeeding. And women also, thirdly, were the main providers of care in their households and in the healthcare settings for people with HIV. I think that it is fair to say that COVID-19 poses a similar triple jeopardy, if not more, for migrant and refugee women. Obviously, we are at risk of infection if exposed. Women from migrant and refugee backgrounds have also been hardest hit by job and income losses. Simultaneously, we also have the lion's share of responsibilities for caring, for housework, family support, and more. That is any support that is needed. There is also an increased risk of family violence and social isolation during this difficult period, which impacts migrant and refugee women disproportionately. The impact of the COVID-19 pandemic on migrant and refugee communities was never more evident than seeing the identification of high numbers of infections in the Housing Commission towers in North Melbourne, and the hard lockdown of the towers that followed. All the pictures or the images that we saw were of Australians, our fellow Australians from migrant and refugee backgrounds, were the ones in the towers and the ones that were locked down. And the information that we got was of a breakdown in communication that happened in people not being properly informed in order to protect their health. So as we are in the middle of the dreaded second wave of COVID-19 in Victoria, and as we begin lockdown 2.0, I think it's important for us to reflect on the things that went well and learn from what we know did not work. Let us not repeat the mistakes that we did in our first response to COVID-19. It is time for us to listen to the voices of migrant women because they do know how to reach their communities. Migrant women's leadership is crucial for us to address the response to reach their communities that have been so seriously impacted by COVID-19. All we've got is prevention. All we've got for preventing, the most important part of prevention is information. And we need to provide the information in an accessible way in order for people to act on them. MCWH are experts in doing this. So we have put out a call to the government to please involve us to reach our vulnerable communities.